screen.
And I'll wait till you're up and running and then I'll.
Okay, perfect. And then, all right, can see that.
It's taking just a second. There we go. Yep, you're up and
Okay,
running. You're good. I'm going to turn off my.
perfect. Well, perfect.
Okay, I'm going to turn off
Okay,
my camera and my mic, but if you need me, I'm right here. Holler, I'll pop back on. Otherwise,
perfect.
I'll see you at the end.
Okay, thank you. Well, thanks everyone. Thanks for joining us. I know everyone has busy schedules, so we really appreciate you taking the time out of your busy schedules. So as Tamara said, I've been here at the center for 26 years, now going on my 27th year. Something else to know about me is I'm recovered myself. I've been recovered for 34 years. And so I'll talk a bit about my recovery. I had anorexia, then had bulimia, had binge eating disorder, and then I kind of feel like my eating disorder was just a mixture of lots of behaviors after that. So I will talk a little bit about my recovery, but probably 10 years into working here at the Center for Change, I had an idea of writing a book. So I started collecting recovery stories from my patients. But I think for me, writing a book is as scary as jumping out of an airplane. So I have not done either one of those. So I have not written the book, but I have made this presentation about what my patients have taught me over these 26 years about how they heal. So the lessons I've learned. And so I will try to get through all 10 therapeutic tools. I am really passionate about social media. So when we get to that section, I will try to not take too long. But no matter what your theoretical frame, whether it's DBT, EMDR, CBT, ACT, hopefully these tools we go over today, you can use with your clients in therapy and in your practice to help them. So when I approached recovery, and I feel like when my patients do, I felt like it was overwhelming. Like it felt like jumping off a cliff, like base jumping. I didn't really know if I could do it. I felt like I was definitely going to fail. And I think for those of you who've been doing this for a while, we see a lot of clients that have relapsed. And by the time I see them in 24-hour care, they've lost a lot of hope and they don't think they can do it. And so it becomes very overwhelming for them. So I think it's really important that we give them tools. And I like to use the analogy of helping them build a parachute. And if you know anything about jumping out of a plane or base jumping or building a parachute or even packing a parachute, it's actually pretty complicated. And it takes a lot of care and preparation and commitment and a lot of attention to detail. And you have to trust the process. They have to trust their team. And you have to know a lot about navigating the descent. And so I like to use that analogy when we think about recovery. I think at first in my recovery, I thought, well, I'll just recover. I'll just do it. I am a little bit of a perfectionist. I got really good grades. And I think I thought, well, when I decide to recover, I'll just do it. It's not really how it worked out for me. And so I really needed to have a plan. And when I work with clients, I like to help them have a plan. And so that's what we're going to be talking about. So when we come up with our plan, the first thing I like to do is teach them the facts. And this is why the work we do is so important. And I think everyone's aware of the mortality rates of eating disorders. You know, before COVID, eating disorders were number one. We had the highest mortality rates. And then during COVID, we went to number two because, of course, the opioid crisis went to number one. Eating disorders went to number two. But that's only the eating disorder deaths we count in this country. And really, right now, those are only deaths attributed to anorexia. If you jump down on the slide, less than 6% of individuals with eating disorders are actually underweight. So we're really not counting individuals that are passing away from bulimia with their electrolytes, um, you know, being unbalanced and dying of cardiac arrest. We're not looking at deaths of individuals that are passing away from that are at a higher BMI, that are restricting and passing away of organ failure. those deaths are not being counted. And I think most people, I think in our industry are aware that as many people die of eating disorders as they do breast cancer, but I don't think the normal lay people are. And I don't think a lot of people are taking eating disorders seriously. And when I look at myself, I didn't take my own eating disorder seriously. I've been at the Center for Change for 26 years, but I've only been the CEO for the last 6 years. In the last 6 years, I've had cancer twice. And I had pretty aggressive cancer. I had melanoma both times, and it's not a cancer you want. But when I had cancer, my treatment team gave me my treatment plan. And when they gave it to me, I looked at it and I was going to have to make some lifestyle changes. And both times I had to have surgery. And the second time I even had to have surgery on my stomach, which was pretty ironic because in my eating disorder, I only cared about my stomach. And it was my stomach was going to have to look different after the surgery. And I looked at that treatment plan and I did everything it said because I didn't want to die of cancer. But when I had my eating disorder, I looked at that treatment plan and everything my team had written down of what I needed to do and what I needed to eat and what medications I needed to take and how often I had to go to therapy and how I had to restore my weight. And I looked at it and I threw it away. And that's why I thank you guys for working in this industry because it's such a hard population to treat. In no other population would we say, I'll get better when I want. I'll maybe start with the lowest level of care and see if that works. When a loved one has cancer, we don't say that. We want to get them the best level of care possible. And when someone has cancer, we don't say it's their choice. But when I had an eating disorder, I literally thought it was my choice. I thought I was in control. I thought I would get better when I wanted. And so I didn't advocate for myself. And I think that's why, unfortunately, out there, people aren't advocating for individuals with eating disorders. Now, this is NIH funding. This is from 2024. Unfortunately, I think when I calculate the 2025 data, it's going to be worse because just the first quarter of this year alone, with the budget cuts, we've lost a significant amount of funding. So right now, for every one individual with an eating disorder, 26 cents goes to research. So this is why knowing the facts and statistics, I think, really matter in this industry because we know so little is going to eating disorder research. So I want to spend a minute to talk about why individuals with eating disorders are not necessarily in control, but why we maybe thought we were, maybe why I thought I was. So before I worked at the center, I had no intention ever of working with individuals with eating disorders. And I actually worked at the VA Medical Center and I was training to be a neuropsychologist. So when neurosurgeons were doing brain surgery and removing tumors or different issues individuals were having, I was in the room helping to map out what cognitive functions that patient may lose. So this is a slice of the frontal lobe. And in this particular scan, you want to see lots of red and yellow, and that means the brain is lighting up and working. And the top part of this brain is the prefrontal cortex. And if you remember, our prefrontal cortex doesn't really develop until we're 25, 26, and that's like the CEO of our brain. So it's like the executive functioning, knowing, is this a good or is this a bad decision? So planning of complex cognitive behaviors and thinking about our future consequences. Like, what is going to happen? So I was doing like a new hire orientation, which I teach for 2.5 hours when I do that. And my son, my 16-year-old son is calling me nonstop. And any of you that have teenagers know their prefrontal cortex is not fully developed. He's calling me nonstop, nonstop, nonstop. And so then he starts texting me. And he's basically telling me he's going to go get his windows illegally tinted. Well, since I didn't text him back, I guess he thought that was me giving him permission to do that. So he got them all illegally tinted. And when I told him he was going to get a ticket for that, Of course, his response was, well, that won't happen to me, Mom. And of course, he said, I won't get pulled over. So that's, their brain's saying, that won't happen to me. Just like in my eating disorder, I said, well, I won't get osteoporosis. That won't happen to me. I won't ruin my vision. That won't happen to me, right? So we lose that thinking about consequences. Empathy. A lot of times, the individual that develops the eating disorder is the most sensitive person in the room. We make great therapists, right? But sometimes parents will say, well, Nicole, I have two daughters. Why did one develop an eating disorder and one didn't? And I said it's usually the one that is the most sensitive in the room. It's the one that recognizes that mom and dad are in a fight, and somehow they think maybe they cause mom and dad to be in a fight, and they're the one that thinks they need to fix mom and dad from not being in a fight, right? They're very empathetic. But you can find when they develop the eating disorder, they lose that empathy. They could be cold to their parents or cold to their siblings. They lose insight into their condition. They lose response flexibility. This is why they can present as very rigid. This is why we can see a lot of OCD behaviors, personality expression. Emotional regulation. This is why they can present as if they're borderline personality disorder, but this is also why DBT works very well with this population. Ongoing decision making, they struggle with this. Moderating social behavior. They have a hard time recognizing how their behavior impacts others. So if you work in a group setting, if you work in residential care or in a PHP setting, they have a hard time realizing how their behavior impacts others. And then impulse control. When they have the opportunity to do a behavior, they want to. We have a drug treatment center around us called Cirque Lodge. They're kind of nationally known. They treat a lot of celebrities. So when I work with them, if they have someone that has an eating disorder and substance abuse, their ability, that impulse control, if they're offered a substance, as one of my patients were on an Uber ride to the airport, it's very hard for them to say no because the impulse control is gone. So I'm going to show you now, this is a brain that could be an anorexia brain. This could be an alcohol brain. This could be a cocaine brain. I've even seen this brain for people with video game addictions. So this is an addicted brain. And you can really see in the prefrontal cortex, it's not lighting up. Now, I've seen some bulimia brains that have a little bit of yellow at the top lit up. I have not been able to see it. I have not had anyone find me an ARFID brain. I'm guessing it looks just like this. The binge eating disorder brain looks just like this. So again, they can still perform. I still performed in college. But if you think of Maslow's hierarchy of needs, it's their ability to get to that higher level of thinking that they're not able to get. Now, this next brain, this would be 90 days, kind of in a recovery behavior free period. Now, this would just be with one substance or just with one disorder. Now, if we're looking at someone that has an eating disorder and substance abuse, depending on if they're struggling with meth or cocaine or alcohol and an eating disorder, we could be looking at 190 days. We could be looking at a much longer recovery time. So this is why PHP, this is why IOP, this is why outpatient treatment becomes critical for our clients. This is why stepping up and stepping down could be so important for their care because they need that structure and that support. And then I like to use the example of my son, right? I have a 17-year-old that struggles with ARFID, and I probably couldn't diagnose him anymore. But what if we're working with adolescents that their brain isn't fully developed? What do with them? Because we know from all the research that earlier we intervene, the better for recovery. The less time they've had the eating disorder, the better. So we want to intervene at an earlier age. We know the prognosis is better, but we also know the prefrontal cortex is not fully developed, right? So I like to use the example of bullying because I am not a good bowler. I actually don't like bullying at all. But when I go bowling, I like to put the bumpers up because if you put the bumpers up, the ball will never go in the gutter. So with our adolescent clients and with our clients in general, and with my son, I need to be the bumpers. Because if I'm the bumpers, they can't go in the gutter. So I've already convinced my 17-year-old son that the University of Utah is the best college in the country. Yeah, I actually think it is a pretty good school. But why have I done that? Because I don't have bumpers big enough to protect him across the country. So when you think about that when treating clients and you think about their aftercare and what they need, what kind of structure and support do we need to give them? So when we think about these tools for success, what are they needing? So we're going to go over the first one that I think is pretty critical, and it's consistency and structure. So when we think about that, I want you to think about first a written plan. Why is a written plan so important? Because number one, I didn't want to write down a plan. And most of my clients don't, because that means accountability. So having them write down a plan, I like them to write down their meal plan. Now, this isn't writing down an eating disorder meal plan of what I'm eating and when I'm eating, but a general plan of when I'm going to eat, kind of a time frame. Who is my support person at meals? Will I allow a support person at meals? And if I do allow a support person, what is their role? Are they going to say something to me at meals? Are they not going to say something to me at meals? And that's okay, but they define it. Having them define times in the day they struggle the most. When do they need the most structure during the day? I also like my clients to have a movement or exercise plan and to be very mindful about movement. So having different levels of movement in their plan and a variety of movement and really looking at mindful and intuitive movement. A sleep hygiene plan. I like all my clients to get at least 8 hours of sleep, but if you're working it with adolescents when their brain is still developing, we want them to get 8 to 10 hours of sleep. And we want that to be pretty consistent. Now, I know that's hard for everyone, but I like that to be part of their plan. The next thing, and I'll talk about this in later slides too, is a self-correction plan. To me, this is key to recovery, but basically, and I'll get to this in a later slide, but really, when they engage in the behavior, what is the self-correction? What are they going to do? And I'll get to more detail to that in a second. Some other things in their structure that I like them to write down. What is their plan for caffeine? What is their plan for substances? For drinking, for smoking, for marijuana, for vaping? Now, ideally, I would like them to stop all these behaviors. I would like them to, if they're not willing to do that, will they be willing to stop for 6 months? Will they be willing to stop for a year? What is their commitments? What are they willing to do? Are they willing to write that down? And then if they engage in that behavior, what is the self-correction? This is their plan. It's not my plan, but we're working with them to come up with their plan because we know if they engage in these behaviors, relapse is much higher, but working with them. Also, social media, we'll get to this in a later slide too, but are they willing to put guidelines down for social media? Are they willing to limit social media? I like them to set daily obtainable goals that are pretty realistic that they can obtain each day, and they write those down. Another one that I think is pretty critical are daily check-ins with a support person. These can just be 5 minutes. And maybe they outline with their support person Just 3 things their support person can check in with them on. How was your day? Did you engage in behaviors? Is there anything I can do better to support you? And then a weekly check-in with the support person that can be a little bit longer, maybe 30 minutes. So I think those check-ins are pretty critical. If your patient is not allowing or not doesn't have a support person, we'll talk about that later too, of why that's going to be critical. Okay, number 2 is honesty. Now, this from the research, these first 3 are in order of importance. So number 1, structure and consistency. Number 2, honesty. My clients have said being honest was what they felt was most important in their recovery, or at least number 2. So one of the assignments I have them do is write their eating disorder auto. This is where I have them put, I like it to be 10 pages, details about their eating disorder. And these are things that they don't want to tell anyone. These were things that I planned on never telling anyone. The things I was so embarrassed about, especially when I was bulimic, I didn't want to tell anyone how I was stealing food from my roommates. I wanted to take that to my grave. So we're going to write down all of our behaviors, and then we're going to share it. And who are we going to share it with? That's where we have to decide. Who is our support team? Who is our recovery support team? So I give them a piece of paper, and the inner circle is who do you feel you could share your eating disorder auto with? Sometimes it's just a therapist. Sometimes it's maybe just a dietitian. Hopefully they have someone else in their life too. A lot of times my adolescents will not put a family member. A lot of times my clients will not put their partner that they live with. That's okay, but let's not say they're a support person, they're eating disorder recovery if they're not willing to share. Now, why are they unwilling to share? Is it because they want to keep the behaviors, or is it because of the shame? And then who is on their front page? They're not in their inner circle, but they're on their front page. So they're still a support person, but they're not willing to share as much. And then who's on their back page? Maybe who's turned their back on them because of the eating disorder, or who have they turned their back on? So for example, for me, I was in college and my eating disorder. My friend reached out to my parents, said how poorly I was doing. So what did I do? I never talked to that friend again, turned my back on. So actually it was a good friend, but to me that was like breaking trust, right? So I have them do that exercise. So the goal is we want to move several people into their circle. I'll bring it up in a later slide, but for introverts, we want 1 to 3 people in the inner circle. For extroverts, we want 3 to 5 people in the inner circle becomes the goal. The next thing with honesty is I have them do a group where they identify basically their matches. Now, I can't actually give them matches, so I give them Q-tips. And these are the behaviors that we're holding on to that we know are basically going to burn down our recovery house. So I do an exercise called red light, yellow light, green light. So red lights are behaviors you're holding on to that are your matches that you know you need to let go of, but you're still holding on to. So it could be like I'm holding on to maintaining a low weight. I'm holding on to still avoiding certain foods. I'm holding on to still thinking I can diet. Yellow behaviors could still be I'm going to restrict certain things. I'm still going to over exercise. And then green behaviors are behaviors I know I need to add to my recovery, like going to therapy, being honest in therapy, reaching out to support people. So I have them identify, and then especially for your patients that have relapsed, can they identify red behaviors they've held on to that they know on this next go around, they need to blow those out. Because again, it's easy to blow out one match, but if I'm holding on to 10 matches, it becomes much, much more challenging. So another rule that I had in my recovery was called the 24-hour honesty rule. So if I was dishonest, I had 24 hours to be honest with my accountability person. Now, for most of my clients, that's their therapist. For other people, maybe it's a different support person. And usually it's an email form. They'll send their therapist an email. They'll say, I was dishonest or I engaged in this behavior. And then the response is, thank you for telling me. What is your self-correction? Now, ideally, we want to close the gap and we don't want it to be 24 hours. But a lot of times for my clients, the 24-hour is a nice starting point. But ideally, we would like it to be day of. But start thinking about what is the self-correction. And we don't want to think about what is the self-correction in the moment. We want to already have a plan of how am I going to self-correct if I purge, if I binge, if I restrict, if I overexercise, if I use a substance, whatever the behavior is, if I self-harm, that I already have some self-correction plans. Because if I wait till it's in the moment, I'm likely not going to do it. So I have what I call the 3 for 3 rule. So I like them to do 3 coping behaviors before they actually engage in the behavior. And then if they do the behavior, what are their 3 self-corrections after the behavior? So this again comes back to building our parachute. This takes planning. So I like them to list all of these 3 things they could do before. I could journal. I could do some deep breathing episodes. I could listen to a podcast. I could have a weighted blanket. I could have a stress ball. I could go walk in nature for 15 minutes. I could have positive affirmations that they already have a list and they commit to doing 3 of those things before they engage in the behavior, whether it's purging, binging, going out running, whatever it is that they've identified as their behavior. Then if they do the behavior, they have to do 3 self-corrections. So usually one of the self-corrections is I seek accountability. I have to be honest with someone is usually we want one of them related to honesty. We may want one of them related to some kind of nutritional replacement, especially if they're restricting or purging. And then I like usually one of them to be related to some kind of self-reflection where I'm actually doing some kind of journaling or writing assignment where I'm realizing what triggered me, what led to the behavior, what did I do. But then there's other things where we really want to focus on some self-care, reading positive affirmations where they're not punishing themselves. So I always get them to do, again, focus on the 3 and 3 rule because that way I'm never going backwards. If I do a behavior, I'm always moving forward because I'm always learning from it. So for them, realizing what triggered me, how am I going to cope? And so having them start listing out what are my triggers? How do I cope? And maybe they identify their top triggers and then what are some ways to cope? And they already have those listed out. So another thing I like them to do is to start rating their triggers. And so I'll go to the whoops, it's not on the next slide. I thought it was on the next slide. But Thomas Cash's, I have his book referenced here in a minute. His workbook, I really like his workbook because he has a whole exercise where you actually rate your triggers from a 1 to 10. And then you look at the duration of the trigger. So how long it lasted, and then how did you cope? So they can actually start seeing was I triggered at a 5 or was I triggered at an 8? And did the trigger last 2 minutes or did it last 20 minutes? And then did I cope positively or did I cope negatively? So patients can actually see how they're doing with their triggers. Okay, so let's talk about negative body image, how they're doing with that, or no, we're going to do reaching out for support first, and then I'll go back to Thomas Cash. So let's go to reaching out for support. That's number 3. And so many of the clients say, They feel embarrassed. They don't want to reach out for support. They get isolated. They feel lonely. And I remember at a period of time in my eating disorder, I preferred to be alone. I preferred to spend the weekends alone engaging in my eating disorder. So I don't know if you guys are aware of this study out of Harvard. It's basically the longest study out there on human happiness. And it started in 1938, and it originally started with 724 men. And they first had a group out of Harvard, and then they expanded it to 456 men in Boston. And then after that, for all the men in the study, their partners, their kids, the siblings, everyone got added to the study. And to be in the study, they had to agree to have their mental health, their physical health, their jobs, their life satisfaction, everything had to be tracked. And to date, this study is still going on. So this is the book. The book just came out, I think 2 years ago, and the study is still going on. And what's crazy is people have not dropped out of this study. And the study was originally looking at lifespan and what made us live long, happy lives and what made us live healthier, long lives. So it was the point of the study. So what's crazy about this is what they found. So number one finding in this study, the most important thing, if you want to live a long, healthy life, and that's why it goes so well with number three, reaching out for support, it's not wealth, it's not fame, it's our relationships and the quality of our relationships. So think for a moment about our clients. And what happens to the relationships in the eating disorder? It destroys them. Most of my clients basically say by the time they come into treatment, they have no relationships, that their family no longer trusts them, their partner doesn't trust them, that all of their relationships are strained, and the eating disorder has taken all their relationships away. And I reference the plane study here really quick. There's so much research that says that, and I travel a lot and I sit on the plane, and a lot of times we just want to put on our AirPods and not talk to anyone. The research says if we would just spend 5 minutes talking to the person next to us, it only has to be 5 minutes, and we can put our AirPods on. It will make us happier just spending that 5 minutes. So again, it's the quality and just connecting with other people. This study also found that loneliness is deadly. In fact, it found that being lonely is basically equivalent to smoking a pack of cigarettes a day. Now, when I talk to my patients in the eating disorder, they said they could be in a room full of people and feel completely lonely and disconnected. The third thing, and this is great news for me because I'm a huge introvert, is being an introvert is not a disadvantage. And quality of relationship is more important than quantity. And just 1 to 2 close connections can be sufficient. And these don't have to be the same connections our entire life. And again, remember, therapeutic alliance is such a protective factor for suicide. And eating disorder clients have one of the highest suicide rates. So even the therapeutic relationship can be so protective for our clients. And just 1 or 2 relationships, and especially when we look at the LGBT and my trans patients. And if you look at the research from the Trevor Project, just having one person in their life, one person that cares about them, can decrease the suicide rates. So again, this research is so meaningful, I think, and so impactful, especially for our clients. So making sure our patients have an entire team. I always say, don't vote the dietitian off the island. If you're a therapist listening, make sure Your patients and your clients have their entire team. They have to have their physician or their MP. They have to have their dietitian, having a team they trust, taking their medications, asking them if they're taking their medications becomes critical. Okay, number 4, letting go of negative body image. These are some things they tell me. Always wanting to change their bodies, refusing to maintain a normal body, hating their bodies. So some assignments I love to get them to do are clothing challenges where we actually do, and some of these are from Thomas Cash's body image book, where they figure out challenge days. They wear clothing that challenges them. They clean out their closets. Some of them say what they have basically their thin clothes and what they label as their fat clothes. We get rid of all those clothes. We have them get clothes that fit them, that they feel comfortable in. So buying new clothes, we do a lot of thrift store shopping because it's new clothes are expensive. Identifying their triggers, what triggers negative body images, weighing in with the professional, so making sure they're seeing their dietitian, having them trust, so getting rid of the scale, avoiding their fears. So finding out what situations are they avoiding. It's summer. Are they avoiding going to the swimming pool? Are they avoiding going to the pool? Are they avoiding dating? And figuring out and maybe rating those in a hierarchy and finding the ones that they feel like they can start trying to do, and then working up to the ones that are the scariest to them. So we literally rate them in a hierarchy and start with the ones they think they can do. And then we set the goals of the ones they really want to do. I just was working with a mom that she has 2 young kids. She wanted to take them swimming this year. So that's the goal we work towards, is to get her to be able to feel comfortable enough to take her kids to the pool. So I thought it was a great body image challenge. Okay, so let's talk about social media because I think this one is so critical. So years ago, I did research on normal media where I exposed eating disorder clients and college-age students to Vogue, Glamour, and Cosmopolitan, 30 images, 30 minutes. Basically, the psychologists that were on my research committee said my research was so damaging that basically it triggered the college women and the eating disorder women so much, their anxiety went up, their body hatred went up, their depression went up, that they said it was so dangerous they wouldn't let me replicate the study. That was back in 1996. That was 30 images. We can't even quantify what girls see now. And of course, we know Instagram and TikTok, those are all the leaders. So it's estimated now in 2025, we'll see about 13 minutes and 13 hours and 50 minutes of media per day. Screen time is kind of what we're going to see. So the recent study shows for Americans, we check our phones 205 times a day. We spend 5 hours a day on our phones. That's about 2.5 months a year. 4 out of 5 of us check our phones within 10 minutes of waking up. 4 out of 5 of us feel uneasy if we leave our phones at home. 2 out of 5 of us look at our phones on dates. 89% of us check our phones at a movie theater. And how about our teens? 9 hours a day on their screens. They get 237 notifications a day. That's about 1 every 4 minutes. So let's talk about social media. It really began taking off in 2010, and the first iPhone came out in 2007. So look at what happened when the first iPhone came out in terms of hanging out with friends. See this complete drop off. And then less dating as well. Complete drop off. So if you're aware, probably everyone's aware of Dr. Haidt's book. It's the #1 book on Amazon right now. And he basically says when Instagram came out and social media, and as psychologists, we're not allowed to say this, but he says social media use does just not correlate with mental illness. It causes it in girls. And I think the research backs it up. So in 2017, 1 in 5 girls between 12 and 17 had major depression. By 2021, 3 in 5 of our girls had major depression. By 2021, 25% of our girls had a suicide plan in high school. Think about that for a second. 25% of our high school girls had a suicide plan. So if you look at the CEDS-C results of the high risk survey, 57% of our girls had major depression. And for our most vulnerable population, our LGBT population, 69% had major depression. 69%. So this graph, it's kind of hard to see the colors, but the very top one is 12 to 17-year-old girls. And look from 2010 up, that's raising rates of depression. The blue line is 18 to 25-year-olds. The green line is 26 to 49-year-olds. And then people like me, the yellow line 50 plus, we're just kind of coasting. But what's going on with our younger generation? I have a 24-year-old daughter, and she's like, well, yeah, Mom, this is normal. This is what we all are experiencing. This one is frightening. Look from 2010 on, these are ER visits for girls for self-harm and suicide. So even the rates for boys have doubled, but look is what is going on for our girls. Why is no one talking about this? So you maybe are aware of what happened in 2021. This is when I went off Instagram, or at least stopped posting. So Frances Hagen, so Instagram has a group of 28 people that are in charge of their eating disorder, their self-harm, and their suicide content. Frances was on that team, and she felt what Instagram has been doing since, 2010 was wrong. So she left under the Whistleblowers Protection Act, and she took 100,000 pages of internal documents with her. She turned them over to the Wall Street Journal, that then turned them over to Congress. And if you remember, Congress did hearings on this. So what did they find? Since 2010, when Instagram came out, they have been intentionally pushing harmful eating disorder, self-harm, and suicide content to our girls. They've known it. They know they're making body image worse for our girls. They know they're making disordered eating worse for our girls. They know they're doing it. They got caught. Even the Democratic senator out of Connecticut made a fake 13-year-old's site on Instagram. He didn't even he just went to a pro eating disorder page, and his whole content became eating disorder. What happened in 2021? They were caught red-handed? Nothing. So nothing. So families started suing. This was the first lawsuit. Their daughter was 11. She had an eating disorder, tried to take her life. This was the second lawsuit. Their daughter had an eating disorder, tried to take her life. So where is it now? So this was an article that was just in Time magazine in June. So if you're interested about this lawsuit, there's now 1,800 plaintiffs. I'm pretty happy to say Center for Change has signed up the most plaintiffs in the last 3 years. It's now in multi-district litigation. If you have any clients that you think might qualify, they have to have been in residential care, they have to be under the age of 30, and they have to have been exposed to social media as a teenager. And so the window to sign them up is closing. But I think this is the only way we are going to make changes, because nothing is changing. This is all Meta has done since they've been caught. So in January of 2024, they said they're going to start restricting self-harm, suicide, and eating disorder content. And then they said they're going to give our kids nighttime nudges and encourage them to get off. I did go with the Alliance last October, and we went as a one-day summit to the Meta headquarters and we met with their team of 28 people. And we met with the head psychologist, Michael, who's over the team. And we were there tasked to make Instagram safer for individuals with eating disorders. Now, I can't share a whole lot because they made me sign 100 pages of non-disclosures. But my takeaway after spending the day with them, they were nice, they were great people. Michael's amazing. But are they going to make the platform safer? If you're an adult, not at all. No plans to change anything for adults. If you're teens, they're talking about it. Do they have any immediate plans? No. No immediate plans right now to make anything safer for teens with eating disorders. So if you do follow Dr. Haidt on Instagram, just this week on Tuesday, he posted a video. And so these are just screenshots from it. You can go on. If I was more techie, I would have shown you the video. So he posed as a 13-year-old. He went in and only liked kitten content of cute little kittens as a fake 13-year-old. This is what he got, is all eating disorder content. So then he went in and reported all the eating disorder content he got. And this is what he got. This post wasn't removed, but we still want to help. So then he went in under their new teen account. At first, the eating disorder content decreased, but then it didn't. So again, nothing is getting better. So please check out his stuff. It's not getting better. So here's an example. If you go on, for example, on TikTok, and young girls go and search mental health or body image, within 2.6 minutes, they're fed content about suicide. And within 8 minutes, they're fed content about eating disorders. So there is a documentary on Amazon Prime called TikTok. I'm not sure if it's still on there. This documentary is a couple years old. It has a whole section about eating disorders. So I could spend 90 minutes on social media. I told Tamara maybe next year we'll do an entire webinar just on social media because I'm so passionate about it. But let's get to number 6, self-care. So some of the things I like my clients to do, one of my favorite assignments is 365 positive affirmations. So they can go online. There's websites that have positive body image affirmations. So they can print them all out, but then I like them to handwrite the ones that they like. And then they put them in a box, they decorate the box, and then every day they take out that affirmation. So really incorporating self-care and then doing daily self-care assignments. So then I like them to do their list of 50, where they list out their 50 self-care. And then you could even say each day, I want you to do one of these. And then maybe build it up to each day, I want you to do 3 of these. And there's some fun gratitude journals they can buy on Amazon if you want them to do some daily gratitude journals. So just building this in. So remember what number 1 was consistency and structure, building in doing daily self-care into their plan. So having this be part of what they do. If you have teenage clients, animals, the CEDS-C even recommends getting them a pet. It does not have to be a dog or a cat. It can be a fish. It can be a bird. So with a lot of my clients, I advocate that that's part of their recovery plan, that they can earn a pet. Lots of my clients have earned pets in recovery. Number 7 is service. So going back to the Good Life book, they found that purpose is more important than payment. Purpose is powerful. I found that with my employees. I don't pay the most, but I have the least turnover in my entire behavioral health corporation because my staff work here for a reason. Now, if you can't find purpose in your job or your clients can't, maybe even where they volunteer. finding volunteer things that they can do. Volunteering their time can become so critical. Number 8 is spirituality. Now, a lot of my clients say they lose this in their eating disorder. And remember, spirituality isn't religion, but for a lot of my clients, they say they stopped going to church or they stopped practicing. So having them maybe say what their goals are in recovery, and spirituality can be a protective factor in their recovery. Number 9 is healthy relationships. Having them identify, are they in unhealthy relationships in their eating disorders? So identifying, are they with a co-addict? Are they, with a are they in a codependent relationship? Are they in an abusive relationship? Are they in a controlling relationship? Are they in a rescuing relationship? And if they are, what kind of, family therapy do we need? And getting them into family therapy in addition to their individual therapy. And so really looking at that part. I've noticed a lot of my younger therapists shy away from doing family therapy. I think it's critical, making sure that support person is engaged in therapy. So the very last one, number 10, is finding balance in their recovery. So letting go of perfection. So this goes back to the kind of the parachute model of, sometimes we only focus on one thing. So filling in each section. So if you look, how are they going to fill in their sections? And so I've given you some ideas, but for them, they may need, what are they going to fill it in with? And how are they going to fill it in? And it's going to take time. I kind of thought, well, this all has to happen immediately for me to recover. And so it could take them time to fill in their circle. And what does it look like to give them balance? And then each panel of the parachute kind of represents support. It helps kind of soften their landing. And if they fall, I just said, I just feel that's part of the process. And that just helps us learn. So to me, a lapse is just part of the process. Falling down is part of the process. But Tamara, do we have time for a couple questions? I think I saved like 3 minutes.
You did so good. You got through it all and you did so good. Yes, we have time. We have a couple of housekeeping items we need to do first, in
Okay.
case somebody needs to hop off at the top of the hour. Will you stop sharing so
Yeah.
I can share the QR code for the test if folks.
Yes.
Thank you. Give me 1 second. Okay, so reminders. So when I stop the webinar, or if you have to leave, the webinar evaluation will pop up on the screen you're currently looking at. So if you would please take a moment to fill that out, we would appreciate it. It's a continuing education requirement for us. Please feel free to be candid in your feedback. It's completely anonymous. And so if you would do that, that'd be really helpful. Then also, let me start again. When I stop the webinar, or if you have to leave, another tab, a separate tab will pop up with the link to take the test to receive continuing education credit. If you would like to take the test and you have to bail out now, feel free to scan that QR code that you see on the screen in front of you. That will take you to the same test. We also will send a follow-up email. Actually, Zoom sends it 24 hours later. So you'll see a Zoom email tomorrow thanking you for coming to the webinar and giving you the link. So if you want to take the test later, that's totally fine as well. Keep in mind that you must take the test online in order to receive continuing education credit. Once you pass the test online, then you'll see a button to download the certificate. So please look for that. Okay, I'm going to stop share so that I can see questions. And Nicole, let me get to those. Give me just a second. Okay, anonymous posted, would you please give some examples of a support person? So who that might be in somebody's life? I know you mentioned it could be family, but can you be a little more specific?
Yeah. I mean, ideally, you would love it to be someone they live with, someone that could actually be there and help do some coaching. But sometimes that is not going to be the ideal person's. You know, a lot of times if it's a spouse, that can cause contention. So who are they willing to be their support person? But I use the example, if I'm going to try to catch a ball, it would be nice to have all my fingers and my thumb. We don't just want to have the therapist. So the more people we can add to the team, the therapist, the dietitian, the physician, are there more people we can add? So I'm always looking to add someone at home. You know, who else can we add? So really encouraging the patients. I would say the people I see relapsing the most are the people that have no one. So even if I'm having them have an AA sponsor, who is that support person I can add?
Thank you. Monica asked, is there a guideline you have for the eating disorder autobiography?
So I used to have them have to read in a group. They don't do that anymore. So now it's pretty much open, but I do like it to be 10 pages typed. So I like lots of detail. And I do like it if they have substance abuse in their history, I like that to be a separate auto. So, because I like to dig into that as well. And then, so I like it just to really focus on the eating disorder and really to dive into those behaviors because I want them to read it in the future too, to remind them how bad the eating disorder was. Because in the future, they may think, well, it wasn't that bad. No, you open up that auto and remind yourself how bad it was.
Thank you. Debbie asked, and this was interesting because you and I talked about this off camera before we started. Debbie asked, any stats yet on how AI, such as ChatGPT, might be affecting eating disorders or suicide or self-harm?
Yeah, well, Tamara and I were just talking because there's a lawsuit about a young man, and Tamara doesn't want to watch the video yet because my daughter sent
I
me a
have to work
TikTok,
my way up to
but a
it.
young man just took his life because a chatbot on ChatGPT, I guess, kind of encouraged him. So I have not watched it either, but I saw some of the comments about it. So yes, I'm really concerned about the role. And some of you are aware that when NITA had their chatbots, it was giving them very bad advice and eating disorder advice. So, yeah, I haven't seen any data or any research, but I don't think it's going to be good.
Yeah, thank you. Alicia asks, are there any resources for family members of eating disorder clients? Also, any thoughts on parenting measures for restricting phone use of children?
Yeah. So the Alliance, for example, has great resources for family support and free groups. If you're local to Utah, we have free groups here at the Center for Change for families. And then if you read Dr. Height's book or if you follow him, he has great guidelines for kids and social media and then also for schools. So there he has some great guidelines for parents. But he basically says it's going to take a village. We're all going to have to do it because you don't want to be that one parent that does it because then your kids feel ostracized from the other kids.
Right. Thank you. Whenever we have a presentation, no matter what the presentation's about, we always have a GLP-1 question, which I love because it's such a big thing. So this is an anonymous poster said, how is access to GLP-1 medications and all of the social media promotion around that impacting clients in recovery?
Yeah, it's hard. It's hard. I have a lot of clients seeking it. I have a lot of clients that obviously would never be eligible for it, should not be on it, that are now on it. And they find all the social media very triggering and very confusing for them. So I feel like as the industry, we're trying to figure it out. I talk to a lot of industry leaders. I'm a member of Red C. We're trying to figure it out because it's overwhelming to our clients. And we're all getting clients approaching us that are on these now. Some that legitimately may need to be, but the majority that should not be on these. So it's hard. It's really hard for the industry right now.
Thank you. We'll do one more question. I
Okay.
apologize. We're actually, if you might have seen our announcement a few weeks ago, we're expanding at Center for Change, and it's right outside my window. Our new building is going to be attached to the wall that's right here, and so you may hear some pounding. So I apologize. I think their lunch hour is over, so now it's noisy, so I'm sorry. Okay, last question. This is from Sarah. How quickly when you meet someone do you have this developed written plan created? I know that you're in 24-hour care, so it may be different in outpatient potentially. Just curious how you might build/establish enough rapport to get buy-in to create this plan.
That is a great question.
Good.
That is a great question. That is a perfect question. You have to do it slowly without patience. And because if you do it too quickly and they fail at the plan, they don't want to come back to therapy. So you have to do baby steps and you have to set obtainable, reasonable goals with them. So I think just by the nature of how she asked the question, she already gets it. She already knows, because you have to do it so slowly and so carefully. Because the data will suggest, especially with clients that struggle with binge eating disorder, if you give them assignments that are too challenging, they're not going to ever come back. So we want to set small, attainable goals that they feel they can reach and that you need to follow up on their homework. So yes, I would do it slowly. I wouldn't even approach it till session 3, and then I would do it very gradually and slowly on their timeline of what they feel is most important first. But yeah, in 24-hour care, I am just hammering them right off the bat.
Awesome. Thanks so much. My thanks to Dr. Nicole Hawkins for the presentation, and my thanks to all of you for attending. We had lots of folks on today, and it was lovely to have you all. Thank you. Some of you reached out just to say hi in the Q&A, which was so lovely. So thank you. Keep an eye on our website and in your email box for our next webinar, which I think is in October, so don't quote me, but I think so. And so you'll find more information to register, etc. when you see that. In the meantime, everybody, please be safe and be well, and we look forward to seeing you next time.
Okay,
Bye-bye.
thanks, you guys.